post-Easter. Hope everyone had a lovely weekend. We are on another webinar for everything Parkinson's. Hold on, give me 1 second. Okay. We are joined today by our movement disorder team. Dr. Diaz is here, Sheila Moore, and of course, our speaker for today, who doesn't really need any introduction, who is going to be talking today about gut health in relation to Parkinson's, our director for the Movement Disorder Center here in Pacific Neuroscience Institute and Providence. Please all welcome Dr. Melita Petrosian. You're muted, Dr. P.
Hi guys, thank you all for joining. Give us 1 second as I am I'm asking permission from Giselle to allow screen sharing, I should say. I know that for many of you, this is a very interesting topic, and it's a question that comes up a lot amongst our patients. So I'm going to try to go into a little bit of the detail, not too much of the detail, and I'm always going to bring it back to sort of how it implies, what can or should we be doing. And let's see if that worked. Yes, that worked. Wonderful. Thank you, Giselle. Okay, so I'm going to present. I should be able to have, yes, I do. I have subtitles starting here. So you will be able to, understand me if I speak too quickly. All right, so we're going to be talking about the gut-brain connection, gut-related symptoms, management of those symptoms, how the gut has implications in how medications are absorbed, and finally ending with dietary considerations. So I wanted to just start with a glossary because, some terms aren't familiar to everybody. Alpha-synuclein is a protein whose abnormal form misfolds and clumps together, contributing to Parkinson's disease. We may hear that term come up. The microbiome is the term for the collection of non-human cells in the body. Mainly bacteria, and I should say best studied are bacteria, but also viruses, fungi, and parasites. Interestingly, we have more non-human cells than human cells in our bodies. So we're just basically walking petri dishes. And then specifically the gut microbiome refers to those microbes that are found in the gut. And then I may also refer to the UPDRS, which is the Unified Parkinson's Disease Rating Scale, and the MDS-UPDRS, which is the Movement Disorder Society version of that. So this is the literal gut-brain connection, which is called the vagus nerve, VAGUS. That has nothing to do with Las Vegas. It comes from Latin for vagus, meaning the wanderer, because it's a nerve that goes from the brainstem all the way to multiple organs in the body, really managing the visceral control of organs such as the heart rate, the blood pressure, how fast or slow the gut is moving. And all of that is mediated in both up and down directions, or we would call them afferent and efferent, and has a relationship to stress and emotions through what's called the limbic system in the brain. But all of that sort of goes kind of in both directions in terms of how hormones like adrenaline, which is also known as epinephrine, or noradrenaline or norepinephrine can contribute to how bacteria are, related in the gut to how the, breakdown of food in our gut is relating to inflammation and other aspects. So in terms of the question of how does Parkinson's start in the gut? Well, one theory of how could it start in the gut would be if there are changes in the microbiome, changes in how the bacteria are breaking down our gut contents, meaning like our food, the way that those metabolites or metabolism products contribute to inflammation or immune regulation may contribute to what's called leaky gut, meaning that those inflammatory molecules crossing from the gut side, which is shown here in brown, into the blood side of the blood vessel, which is shown sort of in the red. And that is thought to contribute to gut and then systemic inflammation, which over many decades can change, is thought to perhaps change the way neurodegenerative diseases are sort of fought off or developed. The other kind of pathway other than through the blood would be directly through the nerves. So as we talked about the vagus nerve then comes down and attaches to the gut, all kind of throughout, sort of intricately woven throughout the gut in a system called the enteric nervous system. And those nerve cells themselves can then, by virtue of how the inflammation is contributing, can result in the alpha-synuclein that was previously normal aggregating, which is another way of saying clumping, in toxic forms. And those toxic clumped forms can go up the vagus nerve to the brain, where the theory goes, they then can spread between cell to cell, as well as within the supporting cells of the brain, which are called glial cells, and then gradually contribute to and cause the death of the dopamine producing cells in the deep part of the brain, which is called the substantia nigra. So it's important to bear in mind, this is a really, really long process. And as our theories are kind of growing of how this occurs, we're also understanding that there's also the balance of, protective factors that are probably at play. And a good example is that, when we think about the genetics of Parkinson's disease, there's no gene that causes 100% of people to develop Parkinson's disease, 100% of people who have that abnormal gene. So, sort of a high, we would use the term penetrance, meaning a high percentage of people with the gene having the disease would be like 25%. So 75% of people who have that same gene abnormality don't get Parkinson's. That means there's something protective that is happening that is also important for us to study and understand better. One thing that we do know is that the gut microbiome has shown differences between people with Parkinson's and non-Parkinson's patients. Some percentage, a small percentage of people with Parkinson's have an even further extent of changes in the gut microbiome, which we call small intestinal bacterial overgrowth. And that has implications for treatment, as we'll discuss. So what are the changes in the gut microbiome? There have been some studies showing an increase in certain bacteria called Akkermansia, Lactobacillus, Bifidobacterium, whereas other studies have shown reductions in Lactobacillus, as well as other bacterial species, as I've described. Theoretically, the connection between these changes in the microbiome can increase the production of short chain fatty acid production. That might be a good thing, might be a bad thing. There's been sort of studies kind of arguing both things can be, that can be in a good way as well as a negative. But there are theories, again, that these changes in the microbiome are associated with inflammation and increased formation of toxic alpha-synuclein types, and then therefore increased clumping of alpha-synuclein. So what is the evidence that Parkinson's starts in the gut? Well, in a mouse model, for example, they did an experiment that was published in 2016, where they took animals and they bred them in a sort of a normal microbiome, but they were free from pathogens, specific pathogens. And they looked at, if you look at sort of the Y column here, that's motor tests that they would put the mouse through, time to sort of cross a beam or how to descend a ladder, how long it takes. So the longer it takes, the slower they are, the more sort of Parkinsonian they are. So the first column in black in each of these is wild type, meaning normal. in a normal environment. And so that we can consider quote unquote normal. The second column, which is clearly abnormal, clearly slow Parkinsonian, is a genetically, a genetic model of Parkinson's with increased alpha-synuclein. They took those same genetically abnormal mice and put them in an environment, and the bottom where it says GF, that means germ-free, where they were raised with 0 germs, and they found that they were no longer Parkinsonian. So the gene required the presence of germs or specific pathogens to become Parkinsonian. Now, of course, humans can't live in a germ-free environment. We cannot do that. We've never done that. We won't ever do that. The other way they kind of evaluated the same thing was by giving those same wild type, meaning normal, and genetically abnormal mice a huge, massive, whopping dose of antibiotics. You know, again, not recommended for humans, but it did show that they were able to prevent the Parkinson's symptoms from developing. And then they did something interesting where they actually took human Parkinson patient, I believe it was, I think they took a stool sample, and they created sort of the microbiome, the Parkinson's microbiome, and they infused that into the mice. And they were able to then, you know, show that the Parkinson's symptoms developed. So this was like, they were previously germ-free, but they were specifically given the Parkinson's microbiome, and the Parkinson's symptoms developed. In addition to the motor symptoms I'm showing here, they also showed inclusions of alpha-synuclein and immune activation within the brain of the mice. Another piece of evidence that suggests that Parkinson's can start in the gut is that in animal models, they cut the vagus nerve, which is called vagotomy, and they found that they were able to prevent the development of Parkinson's. In the normal or the control on the left here, they're giving a specific kind of toxin that induces a Parkinsonian model. And they were able to show that by doing a vagotomy, even with those toxins, it didn't travel up the vagus nerve to cause Parkinson's disease. In humans, vagotomy has been associated with a lower risk of developing subsequent Parkinson's disease. However, Parkinson's disease is associated with slow gut function, which in itself can alter the gut microbiome. So we still have a little bit of a chicken versus an egg situation. Is that the abnormal gut microbiome that causes Parkinson's and then the slow gut, or is it slow gut that then causes an abnormal microbiome? Also, most studies that have been done enroll patients who are already on medications, which in itself might alter the microbiome. And there had been previous studies pointing to Parkinson's starting in the olfactory bulb from inhaled toxins going from the nose into the brainstem. And so there is a possibility that Parkinson's may start in the through the nose into the brainstem and then go down to the gut rather than the other way. Personally, I believe that probably it's all true. It's probably true that it can start in the gut and it could start in the nose and subsequently go to the gut. And I think that the complexity of how Parkinson's manifests, the reaction to medications, the symptoms that patients may have, probably reflects the fact that it isn't necessarily going to be one pathway by which all Parkinson's developed. For example, not everybody with Parkinson's disease has constipation. We talked briefly earlier about SIBO. It is found in about 25% Parkinson's disease compared to about 15% of healthy older adults. It has been associated with worse motor function, can be diagnosed via breath testing, and can be treated with specific antibiotics and temporary dietary restrictions. It's important not to start any anti or probiotics without guidance from a doctor because of these complications and issues to consider. So what are the implications? Now, again, this isn't talking about symptom management. This is talking about preventing progression of Parkinson's disease or treating motor symptoms. How does that gut-brain connection have an implication for somebody who has Parkinson's today? I don't mean to be too negative, but as I mentioned before, that implication is that it was a very long process that resulted in the development of Parkinson's. So the thought that you're going to have a gut management, technique that's going to cure Parkinson's, it seems probably going to be too little, too late. Sort of the cat is already out of the bag once the brain symptoms have developed. There may be implications for some degree of symptom control, as I'll discuss briefly, but also it will probably may play a larger role in preventing Parkinson's in somebody who is high risk. For example, an adult child of a person with Parkinson's who has a strong family history, or who has other risk factors that's pointing them towards the high probability of developing Parkinson's disease. These kinds of things may become important in the future for that population. But something like vagotomy is going to be really high risk. This is not something that is going to be doing anything for a Parkinson's patient. So we're not recommending anybody go get, invasive surgeries on their vagus nerves. Probiotics is, again, very, very big question for my patients. There have been 2 trials that did show benefit for the treatment of constipation and Parkinson's. But again, we're not talking about treating symptoms. Now we're talking about how do we prevent progression of Parkinson's disease. There was one randomized controlled trial that did show a reduction in the total MDS-UPDRS. Those were specifically using lactobacillum. However, most commercial probiotics, the bacteria do not survive. They don't actually result in changes in the microbiome because the stomach acid will break them down. So there has to be development of a proper probiotic that bears that in mind. And again, at least a quarter of people with Parkinson's have SIBO, which could theoretically be induced or worsened with probiotics, specific kinds of probiotics. There have been some probiotics containing TDC producing bacteria, which will become relevant in later in this talk. So probiotics are not without risk. Probably the biggest risk of a probiotic is going to be on the pocketbook because they're very expensive, very unregulated as to what do they contain. And they're not all created equal in terms of exactly which bacterial species they're in them, or yeast, for example, probiotics, for SIBO, and sort of how much do they actually change the gut microbiome. So at this time, I am not recommending probiotics across the board. Prebiotics are undigestible fibers that are thought to help healthy bacteria. So barley, soybeans, raw oats, legumes, onions, garlics, leek, etc. I think there's no harm in increasing the proportion of these kinds of foods in the diet. Certainly, it makes sense, but they haven't been specifically tested for Parkinson's disease. We discussed briefly that sometimes SIBO is treated with antibiotics, but again, don't just go to, the antibiotics in your closet and try things willy-nilly. It has to be if somebody has SIBO, what kind of SIBO, what's the proper course, etc. And again, like I said before, though we looked at those mice models, really antibiotics are not going to be appropriate for somebody who has a human who has Parkinson's disease because we really do need to balance our proper gut microbiome. I do always recommend to my patients to avoid unnecessary use of antibiotics in order to prevent any detrimental shifts in the gut microbiome diversity. So for example, if you're buying dairy or meat products, make sure that you're looking for animals that have been raised with an antibiotic-free diet. I think that's really important. Although, of course, I have no proof that that makes a difference. I think to me, it just makes sense. Again, it probably makes more sense for the relatives of somebody with Parkinson's and preventing the development of Parkinson's disease. There's probably more implication there. And then some of my patients have asked about or even experimented with fecal transplantation. There's no randomized controlled evidence that this works. I will say that the concept would be you take somebody's healthy microbiome and you actually infuse it via a colonoscopy. So, not, bypassing the stomach, going the opposite direction, and try to actually change the gut microbiome. And this was a very small, it was a pilot study. It was about 15 people, completely open label, like everybody knew they were getting the treatment. And in some markers, for example, the movement symptoms, some people improved. Some people improved with anxiety and depression and quality of life as well. Again, I don't put too much weight on that because it's really easy in a small open label study to show benefit because of how strong placebo effect is in Parkinson's disease, at least 30% placebo effect. So don't make too much of that, but the study authors did say they were going to go on to do a randomized controlled trial. So it will be interesting to see if there's still effect. So moving on to management of symptoms, gut-related symptoms in Parkinson's disease. So the thought is that overall, the movement or motility through the gut from, A to Z can slow down, but it's more than just that. There can also be just a dysregulation in sort of how things are supposed to move, how things are coordinated. So please bear in mind, in case you're not developing any of these symptoms, that this does by no means are any of these symptoms universal. These are things that are common, but not, not something that you have to necessarily worry about is going to happen to you. But constipation, very common, typically is a slow transit constipation, but there can be dysfunction of the anal sphincter. The stomach needs to empty also in a normal amount of time. If it takes too long to empty because the nerves aren't giving those proper signals to the stomach to empty, then patients can develop a feeling of being full too early, and that can impact appetite and then cause weight loss, which can be very detrimental. They may feel bloating, nausea, indigestion, regurgitation, there's a diagram below here that sort of shows kind of the concept of food staying in the stomach too long on the right. People can also have trouble with swallowing, both from the oral, meaning how things move within the mouth, as well as into the throat and even within the esophagus. And patients may develop difficulty or a delayed frequency of swallowing their own saliva, which can cause drooling, as well as dysfunction in appetite. So it's very important to bear in mind that not every gut-related symptom is actually from Parkinson's disease. They probably are, but there are certainly cases of hiatal hernias, or pyloric sphincters, or other, stenosis in the esophagus or things like that, where if there is colon cancer, et cetera, if there's a structural abnormality, that needs to be addressed specific to that abnormality. So we can't always assume that everything is coming just from the Parkinson's, because we may miss important diagnoses. So I always, if it's something that's not getting better or it's getting worse, I really like to rely on my GI colleagues, and they like to start with looking at the structure of what's going on. Parkinson's affects really the function of the gut, but the structure also needs to be evaluated. So typically structural evaluation would be like endoscopy, colonoscopy, meaning taking cameras and looking at the gut. That may not give us as much information about the function of the gut, but it's often an important first step because those kinds of structural issues are common. GI evaluations can also include a swallow evaluation, which is typically done with a swallow or speech therapist evaluating. They can also include, in smaller percentages, a colon transit time or a gastric emptying study. And on the right, you see sort of an example of what a delayed colonic transit, meaning slow transit constipation, can look like, where those little white circles and squares and rods are opaque markers that the patient has swallowed. And, after a certain number of days, typically 3 to 5 days, they're supposed to have all left her system. In this case, they're all throughout this person's gut, meaning that things are just moving extremely slowly. And also important part of the evaluation is consultation with a registered dietitian. So management. So, problems with swallowing, again, in conjunction with the evaluation and the speech therapist's recommendation, patients may require a dysphagia diet, meaning something like pureed foods, softer foods, or thickened liquids. at the bare minimum, kind of easy steps to follow for pretty much anybody, regardless of where they're at, is smaller bites, smaller sips, alternating liquids and solids, taking a preventative cough, sort of like a double swallow, or like trying to actually, re-swallow to clear the throat. Making sure to eat mindfully, not like rushing, not lying down, not, distractedly, but, eating while upright, chewing very slowly, and avoiding high-risk foods such as whole nuts, dry crackers, pretzels, tough meats. Some people may avoid, lettuce or grapes or things like that. Some people whose swallowing issues are very progressed may find that there's really no safe way to swallow food, and the discussion may come up of artificial nutrition using a feeding tube. And sometimes in a hospitalized patient that can be temporary, but in some cases may be permanent, and that is a personal choice of each patient if they want to pursue that. And also, is important to bear in mind that speech therapy can actually help for swallow therapy. It's called speech therapy, but really speech therapists, it's more like where they work, in the mouth and in the pharynx and the larynx. So they're experts in helping with swallow, and they can have the patient go through exercises that can help. And there are some expiratory muscle strength trainers that can help with, again, that cough strength to try to improve reduce the risk of swallowing. Moving on to constipation, again, extremely common problem. Talking about just the medication aspects of it. Obviously, food is important in terms of the dietary fiber, green leafy vegetables, water, extremely important, exercise, very important. But as far as the medications go, a stool softener such as Docusate and an osmotic laxative such as Miralax can be really, really helpful. And often that's all that people need. But sometimes people need to move on to a prescription strength gut motility medication such as Linzess or Amitiza. Miralax I really like because it can be used on a regular basis. It doesn't cause cramping, and it can be given, with say like half a capful every day or one capful every other day, and people can sort of titrate to what they need. But one of the really important things to bear in mind about managing constipation is not to let it get too far in terms of how many days have gone between bowel movements. Constipation is much easier to manage when we're being proactive. So again, that's why I recommend my patients to take the Miralax every day, even if it's a smaller dose, rather than waiting until 5 days have gone by. Because what happens when we've gone, 5 days, 3-4 days without a bowel movement is that bowel that's sitting there, that's sort of plugging up the system. It's extremely hard, and then that's literally hard to push out. It takes a lot more strength to push out. Sometimes people may need digital manipulation, meaning putting a finger in the rectum to move things along. Sometimes people use an enema or a suppository to sort of unblock themselves. And unfortunately, sometimes people even end up in the ER because of how backed up they are. We really want to avoid that. What happens after they've kind of unplugged from that really, really firm stool? All of the stool that was those 4 or 5 days of they didn't eat anything, they were still eating, but nothing was passing. All of that stool was sitting too high up, not in the large intestine where the water gets absorbed, but in the small intestine. So that's all that watery stool that's going to come. So, so patients will run into this problem of only treating the constipation when they realize that they're constipated, and then they're taking oral meds to make it softer, and then eventually they pass that hard, heavy stool, and then they get the loose stools following. So then they stop taking anything because now they have loose stools, and then they wait, and then the same process begins again. And one of my patients coined the term constaria, where they're sort of alternating between constipation and diarrhea. So really thinking about how to have a bowel movement every day or every other day, whether or not you need Miralax, bearing in mind that if you read the back of those, it'll say don't use it for more than 14 days. That's for somebody where they don't have a diagnosis. Then, they do want to make sure they get checked before they're treating their constipation over the counter. But if we know what the cause is, it's perfectly okay to keep taking these on a daily basis. The Parkinson's isn't going to go away. The constipation isn't going to magically go away. Really, all of these things, again, I'm not saying everybody needs Miralax, but I'm saying, if the water and the diet and the moving isn't working, have to be aggressive about it. And I'll explain why in a moment. Other issues of GI type symptoms, again, less common but important, is the management of delayed gastric emptying. Sometimes people need to blenderize their food to help it move through the stomach faster. Erythromycin can be used. In this country, the other treatment is metoclopramide, which cannot be used in Parkinson's patients because that exacerbates Parkinson's symptoms. And in other countries, domperidone works well for delayed gastric emptying, but is not available in the United States. Drooling, as I mentioned, can be a quality of life issue for patients. It can also affect kind of the voice if the saliva is sort of sitting on top of the vocal cords. So that's actually very easily treated with botulinum toxin. Xeomin is the one that is FDA approved, but Botox works as well. And that's injected about 100 units every 3 months in 4 spots, and it works really well. So what is the relation with the gut microbiome and your medications? So for most Parkinson's patients who are taking levodopa, this is where this comes to play. This isn't really relevant to other Parkinson's non-levodopa medications like the dopamine agonists or MAOB inhibitors, not related to what I'm about to discuss. This is specific to levodopa. So levodopa or L-dopa, as you can see on the left side of the screen, it needs to cross into the brain. And this gray bar here represents what's called the blood-brain barrier. So through the blood that's circulating in and around the brain, levodopa can cross. Dopamine cannot cross, only levodopa can cross. So levodopa crosses the blood-brain barrier, gets into the brain, and gets converted into dopamine, resulting in the positive effects of treating symptoms of Parkinson's disease: reduced tremor, reduced slowness, reduced stiffness. On the left side of the screen is what's happening in the gut and periphery. So if levodopa gets converted into dopamine outside of the brain, in the gut, the side effects can include nausea and low blood pressure and lightheadedness. So with levodopa always comes a dopa decarboxylase inhibitor, meaning something that blocks the enzyme that converts levodopa into dopamine, in order to have less dopamine in the gut or periphery and more of the L-dopa crossing into the brain. And the main one in the United States is called carbidopa. So that's why we put those two meds together. Fun fact, the term Sinemet, which is the old brand name for carbidopa and levodopa, was sort of this bastardized Latin for sin, meaning without, and emesis, meaning nausea. So the thought was that putting those two together, you would reduce nausea. So you can imagine how much nausea people had when back in the day in the 60s it was just levodopa on its own without the carbidopa. So how does the gut bacteria play a role here? So there are certain bacteria that can actually convert the levodopa into dopamine in the gut, meaning that there's less levodopa getting absorbed into the brain and therefore less dopamine and therefore less on, either a slow on or a early off or a no on kind of situation. And so though we would hope that the carbidopa would stop that, it turns out carbidopa only works on the human enzyme, and it doesn't work on this bacterial enzyme that is involved in levodopa metabolism. And I have to say, I tell my patients this and they sort of nod along with me, but to me, when I heard about this, again, 2 years ago, 2019, like my brain exploded. Like, this is mind blowing to think that, it's not just about human drug metabolism, it's also bacterial metabolism plays a real role in how our medications are being absorbed. This is a huge breakthrough in our understanding. So what affects levodopa metabolism? It's specific bacteria, Enterococcus faecalis and Egerthella lenta in this particular study that were identified. Specific enzymes of Enterococcus faecalis, again, tyrosine decarboxylase, which is abbreviated TDC, which is what I had referred to earlier, that some probiotics can actually contain Enterococcus faecalis that has TDC, so you would definitely not want to be taking that. And specifically, there are some gene variants within these bacteria that code for either the TDC enzyme or other enzymes like DADH. So the concept is that we have to not just know about our own, metabolism, our own enzyme, our own genes, but also those genes of the bacteria. So it really gets very complicated very quickly in terms of when we're trying to understand how the gut microbiome affects us, both as far as the development of Parkinson's and the management of Parkinson's with levodopa. It's, what are the levels of the bacteria, which enzymes do the bacteria have, what are the genetics of those bacteria. So it's very interesting, but I do think it's going to eventually get us to a place where we are able to manage this better. But for now, it's very complicated. There has been, evidence that as the disease progresses and as the number of years that somebody's taking levodopa is increasing, both of those things can actually shift the gut microbiome to increase the amount of that TDC gene carrying bacteria, the bad enzyme or the bad bacteria, and therefore result in reduced absorption, reduced availability of levodopa, and therefore people need to take the levodopa more frequently. And that sort of creates this vicious cycle issue of, creating more and more issue is the thought. And so, this might help us identify a biomarker for what is the proper levodopa dose, how are we going to manage that, as well as interestingly, work being done on blocking that bacterial enzyme, specifically TDC. And as I mentioned, there's at least one other bacterial enzyme we know of that also can metabolize levodopa. So there's probably other ones too. But the concept is that there is an amino acid that is being developed to try to manage motor fluctuations. This worked in mice, again, needs to be tested in humans. But the concept was in blue, we have, I should say in red, we have kind of normal. The mouse was taking carbidopa levodopa, and they had a certain amount of levodopa in their brain, with time. But when they gave those mice the carbidopa levodopa plus this amino acid blocking the bacterial enzyme, they had even more levodopa in their blood. So it is relevant to, what will hopefully be management of these kinds of issues in the future. I also kind of think that this illustrates kind of that frustration that a lot of our patients have as to, frustration of the unpredictability. Why does today it take me 30 minutes for this med to kick in and tomorrow it takes 45 minutes? Why does this dose last 3 hours and tomorrow it lasts 4 hours? And those changes in the gut microbiome are probably playing a role in terms of what the bacteria are metabolizing. So what does this mean for Parkinson's patients? As GI symptoms progress and the gut is slowing down, the onset of action of levodopa can be slower. Typically, levodopa should be taken on an empty stomach, as protein in the gut can interfere with the absorption of levodopa. Typically, the levodopa should be taken at least 30 to 60 minutes prior to having a meal. If the meal is going to be delayed or skipped, the medication should still be taken on time. Otherwise, it gets too crazy for patients to try to remember when they ate, when they're going to take it, and then people get delayed doses and skip doses. So I say try your best to take the med on an empty stomach, but don't drive yourself crazy, just bear that in mind in terms of trying to plan your schedule if possible. The medication can also be taken 60 minutes after finishing a meal. Constipation should be treated aggressively because as slow as the gut is in moving, that's how long it's going to take for the levodopa to kick in, as well as the other issues that I mentioned of constipation potentially playing a role in those changes in our gut microbiome, and therefore those changes of the levodopa absorption that I mentioned earlier. The other implication is, well, why can't we just bypass the gut entirely? The gut is an issue. There's these microbiome issues. There's the slowness issue. Let's just bypass the gut completely. And so that has been developed. Already on the market are two items. One is called Inbrija, it's the inhaled levodopa, and the other is called Kinmobi, it's the sublingual dopamine agonist. Both of these bypass the gut. However, they don't last very long, so they're only thought to be sort of like a rescue treatment for off time. We've talked about this in other talks this year. But that was sort of the thought. The other thing that is in the works of being developed, again, bypassing the gut, is the patch pump formulation of levodopa that's going to go directly into the skin. That's still in the works, but that is looking promising for eventually getting FDA approved. And finally, for the issue of sort of how long it takes for it to go into the gut, there is the intestinal infusion of levodopa called Duopa. That's been available for a very long time now. And that is still relying on the gut to absorb, but because it's a continuous infusion, there's less concern about when did you eat, when did you not eat. So how to sort of take meds consistently, or why is it important? Taking meds consistently is thought to reduce the risk of developing dyskinesias, as well as reducing the risk of on-off fluctuations. It is important to use technology as necessary, such as a smartphone or a watch, to alert people. Nobody is really capable of remembering to take their meds every day, on time, every time. We're not good at that. We're humans. Life gets busy. So use technology to, I always put like a timer. You can label the alarm on your phone so that it tells you, when to take it. And then finally, moving on to dietary choices. So in general, I do think that the MIND diet probably has the most evidence for utility in Parkinson's disease. It's been studied in Alzheimer's more extensively and found to reduce the risk of developing Alzheimer's disease. But I think that there's equal validity or reasonably equal conceptual validity in Parkinson's disease. So the MIND diet stands for Mediterranean Intervention for Neurodegenerative Delay. So the concept would be whole grains, green leafy vegetables, other vegetables, berries, nuts, beans or legumes, poultry, fish, and olive oil. Now, some patients may have a glass of wine. Again, this was developed for prevention of Alzheimer's, where balance wasn't as much of an issue. I tend to get a little bit nervous about the wine part of it. I don't know about purple grape juice, maybe, maybe not. I would probably just skip that part of it, not worry too much about the red wine. Other aspect of it is what not to eat. So really, really trying to be good about limiting sweets. I think that's probably the biggest one. And it's probably important to limit red meat, butter, cheese, and like fried food, fast food, processed food, those kinds of things. But I suspect the sugar has the biggest role there. So there are so many other considerations when it comes to what your diet should look like. And that's why I think, if it were up to me, I would say everybody should get a consultation with a dietitian. Unfortunately, insurance companies aren't asking Dr. Petrosian what I think. So sometimes it is an out-of-pocket for that consultation. But if it's something that's possible, I would certainly recommend it, to sit down and sort of look at what are your preferences, what are your other restrictions, either religious or, maybe somebody has a lactose intolerance or whatever. And then within Parkinson's disease, the concepts of dysphagia, weight loss, SIBO, delayed gastric emptying, all of these have different dietary recommendations. And then to a lesser extent, neurogenic orthostatic hypotension may play a role in how much salt somebody should or shouldn't be having. So, I think that there isn't like one diet that everybody with Parkinson's should follow. I think the concept is, if you're not having any of those symptoms on the right, then, try to follow the MIND diet. But if you are having symptoms, bear in mind, having a consultation will probably make sense. The other aspect of weight loss is that we do have, a small percentage of our patients who are overweight or obese, and there has been association with metabolic syndrome with overweight and obesity, and that meaning like glucose intolerance, elevated blood sugar, elevated blood cholesterol, elevated blood pressure. These things have been associated with a faster progression of Parkinson's disease. So management of obesity and overweight is really important. But if somebody is underweight, or if they have a normal weight, losing a lot of weight can unfortunately cause loss of muscle. Unfortunately, our bodies are very good at hanging on to fat and not as good at hanging on to muscle, especially if we're a little too sedentary. So weight loss is really important to kind of bear in mind as far as, sometimes it's a good thing, sometimes it's not a good thing, and making sure that, people are maintaining a healthy weight is really key. And so one last final point I want to make, or sort of next to final point, is do your best. Don't let perfect be the enemy of good, because I think sometimes it's tempting to feel like, oh, well, I cheated a little bit. I had like that extra chocolate bunny over Easter. And then it's like, well, cat's out of the bag. I might as well have this whole sleeve of Oreos now, and it's like, no, you can slip, you can sort of think of it as an incremental approach. Like if somebody, I had a patient who he would have cereal every morning, and in his cereal, which was already sugary because it wasn't like, Cheerios or something like that, some kind of sugary cereal, he would add 6 teaspoons of sugar to his cereal every morning. I was like horrified. And it's like, for somebody like that, I'm not going to get him to have sugar once a week. That's not going to happen tomorrow. Like that's not going to be sustainable for him. He's going to need to work his way down to like 5 teaspoons, 4 teaspoons, 3 teaspoons to change his palate, to adjust his palate so that sweet things stop tasting palatable and start tasting like, ugh, this is just way too sweet. That's a gradual process. So really important to give yourself that time to adjust, to be kind to yourself, to enjoy food when it's meant to be enjoyed, but not to sort of eat mindlessly, and just to be more mindful about the choices that we're making. And the final thing is a little shout out to Giselle, which is her saying of simple but not easy. Water intake, again, really, really important for management of constipation. We talked, I think, maybe I skipped the part about fiber. I may have kind of gone past that one, but fiber intake, soluble and insoluble fiber, they work better when you're drinking the water. So it's, again, we can't like, I've seen like sort of these like gummy, fiber gummies. And it's like, well, the whole point of like the psyllium in water is it forces you to drink the water, or like Miralax, it's in water, it forces you to drink the water. Again, Giselle likes to say simple but not easy, because water is free. There's very few side effects. Maybe don't drink it like right before bedtime, but it's really, really important. But it's not always easy to continue with those choices. So again, try your best. Just bear these things in mind. When you start to feel like, well, I'm slipping, just forgive yourself. We're all just trying to do the best every day, and try to bear in mind the dietary choices and the water intake and walking activity, those kinds of things, as far as managing gut symptoms. And eventually, hopefully, that will play a role in how you feel with medications as well as your motor symptoms in general. That's all I have. I think that gives us some time for questions. I'm going to stop my share.
Thank you so much, Dr. Petrosian. Definitely, so many things in life are simple but not easy. We do have a few questions here. Are people that have IBD sufferers, are they more inclined to have Parkinson's?
Oh, IBD.
IBD, yeah.
I think I think I do recall seeing a study. Natalie, I think am I remembering that correctly? There was like an associative study. Yeah. It's not there was, right? For a couple of years back. Yeah. So it's, again, most of our patients don't have IBD, but I think there is a slight increased risk. Again, probably having to do with gut inflammation and systemic inflammation. There's, more and more that's being learned about how systemic inflammation plays a role, because we don't think of Parkinson's as like an autoimmune condition like MS, but there's more and more understanding of how the immune system plays a role with the glial cells, meaning those support cells in protecting brain cells. So I think that there's a role that it plays, but again, it's not the only thing. Again, it's that complexity of Parkinson's that we've been talking about this year of, it's not one thing, it's multiple kind of contributions.
Yeah, can I just say something?
Yeah, go ahead.
Yeah, I mean, there's multiple studies, and I think that patients always, when they read the literature, have to understand when we talk about associations versus causation. And what that means is that, you take a group of people that have Parkinson's and don't have Parkinson's, and they're people that have Parkinson's, more people have inflammatory bowel than those that don't. But that doesn't necessarily mean that it's causal. It means that there could be other things at play that could be causing both. Right? So it just means there's an association. So when you see that association, it doesn't mean that one thing leads to another. Both are, it's more common if you have Parkinson's, but it doesn't necessarily mean that it causes it.
Good point. Thank you. I see some really, really interesting questions here about does gut-derived alpha-synuclein have symptoms? And the thought is yes. So many people have constipation for a decade or so before they develop the motor symptoms. So nausea, constipation, etc., is thought to be the manifestation, but many people may have no symptoms at all. The other question was about if once the abnormal alpha-synuclein crosses the blood-brain barrier, what happens to the normal unfolded proteins? Unfortunately, there has been some research showing that there is they sort of glom on to each other, and the abnormally folded proteins kind of accelerate or induce these normal proteins to misfold themselves. So that's the thought of this sort of outside the cell spread to other cells and other proteins. Unfortunately, they then kind of induce the abnormal folding in other proteins. And then good question about what should somebody ask if they're getting a colonoscopy or an endoscopy, what can they do? I don't think the colonoscopy endoscopy specifically is, has any kind of Parkinson's specific questions, because that's, again, just the structure. So, and anyway, they actually are cleaning out your gut. They're not looking at the stool there. They're not looking at bacteria. They're looking at what's on the walls, is the way to put it. Is there any narrowing? Are there any polyps? Things like that. But I think that, there are I have seen some reports where patients have had kind of their gut microbiome levels sort of looked at in terms of what are pathogenic. I haven't seen that as yet to be specifically, okay, let's look at your TDC levels or other enzymatic levels. But I think that may eventually become developed with further collaboration between, gastroenterologists and neurologists, or sort of the PD community. But that's a really good question.
Dr. P, there's a question here about what role does diet play? I wasn't really sure if we're asking whether diet is a result to PD eventually, or is it in relation to constipation? I wasn't clear about this question.
Yeah, I mean, I guess, the question of sort of the typical American diet contributing to Parkinson's. I mean, Parkinson's is all over the world. I don't think that it's specific to the American diet, but I do think that, some of the other aspects that have to do with, life in industrialized countries, such as the water pollution, air pollution, plastics that we're apparently ingesting and have now kind of embedded in us, like these kinds of things. Again, they're extremely long processes, and a lot of people are exposed to the same toxins or, you know, issues with their diet. And, you know, the majority of people don't develop Parkinson's. So again, not to sort of repeat myself, but it is extremely complex in terms of what is that interplay between our genetic predispositions and those toxins or the bacterial profile. You know, the microbiome, I think there's a lot of interest now in terms of kind of what should the proper gut microbiome diversity be. But it's probably clear, it's you know, reasonable to believe that kind of the Western society and sort of the cleanliness of you know, what we're, you know, surrounded by in terms of nowadays, of course, it's even worse with all of our necessity of using our, you know, hand sanitizers and all of that, you know, contributing to, you know, changes in the gut microbiome of the animals or the things that we're eating, and that playing a role. Again, the bare minimum I can ask people to do is try to avoid antibiotics in your food. Like, because I think what was it, like 75% of antibiotics that are distributed in the United States go to livestock. They don't go to humans. So it's like, that needs to, there's other reasons why that should stop, you know, from the perspective of antibiotic resistant bacteria, et cetera. You know, I think that the concept is we can only do the best we can now, and maybe like encourage or educate our, you know, younger family members of what those implications are for the diet that they're having in their 20s and 30s, that may end up catching up with them later in their life. Relevance of good sleep, meditation, and yoga. I mean, I think that the concept would be, as I mentioned in one of that first slides, the vagus nerve, that gut brain connection, you know, it's stress levels probably have a role in how we're metabolizing our food and those kinds of things. So I think there's a relevance there. I don't know if it's directly connected to the gut brain connection, but obviously sleep, for example, lack of sleep can contribute to enzymes and hormones that can impact the inflammation as well as our, you know, immune system. So I think that, again, it's all in that interplay. It may not specifically be in the gut brain connection, but it's all related. And we know about, you know, meditation and yoga kind of improve the balance of our parasympathetic nervous system compared to our sympathetic nervous system. So the sympathetic nervous system is the fight or flight response, and that tends to shut our gut down, which makes sense. If we're running away from a tiger, we don't want to be stopping to use the bathroom on the way. So when there's a lot of kind of pent up stress and sort of like, you know, tension like this, the cortisol levels are high, you can imagine that that is, you know, there's an imbalance, whereas the parasympathetic nervous system is the rest and digest system in terms of allowing blood flow to the gut, allowing the gut to move. And so I think that, yeah, stress reduction, as far as how we are adapting to stress, again, calling back to Sheila's excellent lecture last month, you know, not about necessarily avoiding all stressors, because some stressors are good, but sort of understanding what our mindset is and how we're going to manage those stressors, I think, are probably going to play a role. There was a question about whether somebody should take probiotics while taking antibiotics. I'm not sure is what I'm going to say. I haven't been sort of giving a blanket statement to advise my patients to do so. I think that, you know, there are those who recommend it. Because I just wouldn't know which probiotic to recommend, I have not been sort of recommending that. I don't know that it's necessarily counterintuitive, because the antibiotics versus probiotics, your probiotics are going to be sort of the good bacteria, but I can't specifically recommend that. And then Senna, question about Senna. Senna is a natural plant-derived stimulant laxative, also called Senokot, but it can be a bit too, it can cause some cramping. It can be a bit too much. I think most people don't recommend it for longer term use. So it's okay to use on occasion. And the very good question of why do we have this bad boy protein in us That's a really, really good question. There is a lot of work that still needs to be done in terms of identifying what is the role of alpha-synuclein when it's normal. What are the roles that it plays? Because we're talking about it when it's in its toxic form, but it does have a role in its normal forms as well. And then what if one has a wide spectrum antibiotics and eliminates gut bacteria? Again, don't recommend to do so for Parkinson's. If somebody needed a wide spectrum antibiotic, as some of you may know, a side effect of that can be the development of what's called C. diff, which is a bacterial infection of sort of the bad bacteria proliferating now that the good bacteria have been wiped out. Again, some people would recommend a probiotic. I just wouldn't know which one to recommend. I would probably advise people to ask their internist or gastroenterologist for that question. And then, is kombucha okay to drink? I'm okay with fermented foods to a certain extent. You do want to be careful if you're taking an MAOB inhibitor not to overdo it with fermented foods, such as kombucha. But I don't think that it's something where it's like, I think there's enough evidence to say, oh, everybody has to be having a ton of fermented food from the Parkinson's perspective. I don't know if Dr. Diaz, you have other thoughts about the kombucha or the probiotics when somebody's taking antibiotics?
No, again, there's no hard and fast rule on this. I usually try to dissuade patients from going out and spending a lot of money on these preparations, and you could drive yourself crazy, like diets, what's the right thing to do, what's not the right thing to do. And I think people always have to keep in mind that, we think Parkinson's probably has been around for, a very long time. It's been described 200 years ago with James Parkinson, and it was described, we think, in ancient texts when their diet did not have processed foods, did not have these high fructose, high corn syrup, antibiotics weren't involved. So, there's much more to Parkinson's than just the gut, but we do think it plays a significant role. And I think driving yourself crazy with these, your diet and supplements. So I generally tell people, stay away from all that expensive stuff. Kombucha is fine, fermented drinks. There's some evidence as a prebiotic that fermented drinks can be good, but just don't overdo it. Everything in moderation is always my motto.
Yeah, I love that. Thank you for that interesting thing. I haven't looked into like the ancient manuscripts about, shaking or those kinds of things. That's super interesting to kind of bear that in mind, that these really aren't new diseases. They're not like industrial, they're not limited to people in industrial settings, et cetera. But just sort of illustrates that, we're just trying to do kind of the best we can as far as if there are things that will improve, let's try that, right? Like if your example, cutting out sugar is going to help us, let's do it, but understanding that it isn't the main thing. You could have somebody who's, a strict, keto or whatever, and they may still develop Parkinson's. So, I think it is important not to go a little overboard, but just to try the best that we can.
Okay. Thank you so much, Dr. Petrosian and Dr. Diaz, for your expertise too. Dr. Petrosian, that was a really wonderful presentation today. Thank you so much. We definitely learned so many things today, a lot of things to think about for sure, and a lot of information too. I just want to reiterate, we've been getting emails too with regards to the presentations. The videos will be available in our website soon. The site is still being built, so hopefully we will have it at the end of the month, but we will let you know as soon as that is up as well. So that is it for us today. Thank you so much for being here, and thank you so much for all your questions. We will see you back next month. We are going to be talking about sleep next month. So see you then. Thank you very much and have a wonderful week. Take care, everyone.